in adults. This is extremely important that we are talking about adults. Okay, you must remember this. The camera is there. You must remember this. The most common, it is associated because of long-standing acidopathic disease, or it is a gastric carcinoma. So it is either benign disease with a long-standing history of acidopathic symptoms, or it could be a short history, but it could be because of an underlying malignancy. So this is extremely important to remember. Okay? The bottom line is that you should consider it to be malignant unless proven otherwise. Okay? Gastric outlet obstruction, ये मेरा arrow नजर आ रहा है? Farida Gul, can you see this? Kiran Abdul, yes, sir. Okay, very good. Now, this is the stomach, the esophagus, gastroesophageal junction. This is the stomach itself. This is the first part of the duodenum. This is pylorus. Now, here when they get obstructed, the stomach starts to get dilated. Okay? And that is, once you can't go beyond, the food cannot go beyond the stomach, this is known as gastric outlet obstruction. Okay? Now, remember one thing. एनाटॉमी याद रखोगे जिंदगी बहुत आसान हो जाएगी सिम्टम्स बताने के लिए ये सेकंड पार्ट ऑफ duodenum this is the second part of the duodenum and the CBD opens into the second part of the duodenum so the bile that is synthesized in the liver stored in the gallbladder actually drains into the second part of the duodenum and the obstruction is at the pylorus here proximal to the second part of the duodenum. है ना? Understood? So now the clinical feature क्या होगी? भाई abdominal pain होगा, gastric distension होगी, पेट में आप खाना खा रहे हो, it is distending. You take the food, it is distending, but it is not moving forward. So what happens? You start to have abdominal distension and pain. And when you will vomit, what will happen? The food particle that you had taken in previously is the one that is going to come out. But there will be no bile. Why? Because the obstruction is proximal to the ampulla of water. Correct? Therefore, it will be a non-bilious vomiting containing food particles. And of course, whenever a person vomits, you become dehydrated. Now, once you are dehydrated, you can have all the symptoms of hemodynamic instability. वो एक अलग बात है. आपको weakness हो रही है, आपको क्या कहते हैं, electrolyte imbalance हो रहे हैं, and you know things like that. Now, it is very important that you know what electrolyte imbalance occurs in gastric outlet obstruction because this is something that everyone will ask, no matter which exam you go into. और अभी नहीं, सिर्फ MBBS में नहीं. Even when you are giving a fellowship exam in surgery, you will have to know what is the actual metabolic disturbance, electrolyte and acid base capture. तो वो होती है बेटा hypochloremic metabolic alkalosis. We will explain, I will just explain to you in the next slide how it happens. But for now, remember that the metabolic disturbance, electrolyte imbalance and acid base impairment में hypochloremic metabolic alkalosis होती है. And one of the signs that you will be able to elicit is succussion splash. Succussion splash is when you put your stick on the epigastric region and shake the belly, you will feel the water like in a bag, water splashes. I think every one of you must have someday tried ये जो पानी की बोतलें होती है प्लास्टिक में, उनको हिलाते तो छप छप आवाज आ रही होती है. That is exactly what you can hear in your ears with your stethoscope. Yeah. Now, if you look at this X-ray, which is a barium enema, you see a hugely dilated stomach with narrowing here. Now, this is gastric outlet obstruction at the pyloric level. Now, this is the first part of the duodenum, and the second part is here. So, the CBD from the liver bringing the bile is ending up here somewhere, and the obstruction is proximal to it. And that is the basis of why you will have a non-bilious vomiting, which is containing undigested food particles. समझ आ गया? If you want me to repeat this concept, because this is extremely important, because this is when you will suspect that this is gastric outlet obstruction. If you want me to repeat, write down right now. Understood? Right? Yes, sir. Yeah. Yes, ही लिख दो. Yes. Good. Concept समझ आ गया. अब next slide पे चलते हैं. अब हम बात करेंगे यही hypochloremic metabolic alkalosis क्यों हो रहा है. Right? When you are doing, when you have a gastric outlet obstruction and you are vomiting, what are you vomiting? You are basically vomiting the gastric acid, correct? Which is hydrochloric acid. So you end up with, you lose chlorine, you lose acid, hydrogen. So you end up with hypochloremic alkalosis and dehydration. Once you have a dehydration, the renal compensation gland, which is the body's internal milieu, comes into play. So at the renal level, you have bicarb and sodium loss, hyponatremia with profound dehydration. Okay? So sodium is retained. So, sorry. So the sodium starts to be retained, potassium and hydrogen is excreted. So in the urine, you have paradoxical acidic urine. Paradoxical acidic urine. You're losing acid in the stomach. From the stomach, you are also losing, the urine becomes acidic and hypokalemia, which is loss of reduction of potassium. So you start with vomiting of hydrogen chloride, which causes hypochloremic alkalosis because you are losing chloride, you are losing the hydrogen, which is responsible for the acidity. The renal compensation sets in, bicarb and sodium loss occurs. This leads to hyponatremia and profound dehydration. Body tries to retain the sodium in exchange for excretion of potassium and hydrogen, which leads to paradoxic acidic urine and hypokalemia. So now you have the metabolic response of, what is the metabolic response? क्या होता है metabolic derangement in gastric outlet obstruction? Hyponatremia, hypocalcemia, hypochloremic metabolic alkalosis. समझ आई? हेलो, यस सर, ठीक है, गुड. अब डायग्नोसिस बड़ी आसान है भाई. डायग्नोसिस हमने ऑलरेडी आपको दिखला दिया है. क्लिनिकल फीचर्स जब होंगे, आपने बेरियम मील कराना है या अपजिया एंडोस्कोपी कराना है ना. बेरियम मील कराएंगे, आपको ये पिक्चर याद आएगी, नजर आ जाएगी. ये जहन में रख लो पिक्चर. Keep this picture in your mind. Everyone understands Urdu and English both, right? Because I sometimes go into Urdu. So don't worry, okay? All of you understand Urdu and English both, correct? But I'm trying to keep English mandatory so that I am, if there is anyone who doesn't understand, you can. Okay, very good. So this is the picture you must remember, where you have a barium meal showing dilated stomach, narrowing here, and partial of dye going into the duodenum. You may actually have complete obstruction, in which case there will be no dye in the stomach, no dye in the duodenum, and stomach will be distended, dilated, and will have a picture like this without showing duodenum with dye. This shows a streak of dye going across the pylorus here. Okay. So the investigation is either barium meal, X-ray, or you do a upper-GI endoscopy. Now barium meal X-ray जो है वो क्या होता है कि उसमें डाई पिलाते हैं आप, कंट्रास्ट डाई पिलाते हैं जो X-ray पे नजर आए, जैसे यहाँ पे नजर आ रहा है ये व्हाइट वाली. Then you take a picture, ठीक है? Okay. अपर GI एंडोस्कोपी क्या है कि आप मुंह के जरिए दूरबीन डालते हैं, you put in the endoscope and you physically see the pylori and try to enter the duodenum. And in case of obstruction, you will not be able to enter the duodenum. So the management is, of course, when you are losing so much of fluid and you are having electrolyte imbalance, is resuscitation. Correct? First thing is give IV fluid. Okay? Normal saline. Do gastric lavage, because if you don't do gastric lavage, how will you do endoscopy? Because all you will see is food particles. So put in a nasogastric tube, do a lavage, remove the food particles and food stuff, keep patient NPO and ask the patient, ask your gastroenterologist colleague to do an upper GI endoscopy. Upper GI endoscopy will either show you either if there is a growth, it could be gastric cancer, or it could be in a long-standing history of acid peptic disease, fibrosis and narrowing. Always take biopsy data. We must have biopsy, making sure if cancer is. And the treatment is usually surgery. Now, if you have a benign disease, gastric outlet obstruction, all you need to do, either you do a gastrojejunostomy, you take a part of the stomach and stitch it with the jejunum. This is known as gastrojejunostomy. Okay? Or you can do, if it is a benign condition, you can do pyloroplasty. That means you open up the scarred area longitudinally and stitch it transversely. Okay. Now, I'm rushing through because मुझे नहीं मालूम हो सकता है आप लोग की next class हो गई. तुम लोग की कोई next class है? हाँ, तो तुम लोग ने मेरे साथ तो बहुत जबरदस्त काम कर दिया. अच्छा, अब अगर malignancy है, if it is malignant gastric outlet obstruction, it is usually CA stomach. CA stomach में you have to do क्या कहते हैं, मैनेजमेंट को फिर बाद में कर लेते, बेटा आगे चलते हैं. ये गैस्ट्रिक कैंसर अगर स्टमक है तो यू नीड टू नो द एटियोलॉजी. द एटियोलॉजी इज गैस्ट्रिक कैंसर की मोर कॉमन इन मेल फैमिली हिस्ट्री होती है, ब्लड ग्रुप क्या कहते हैं ए में ज्यादा कॉमन. ठीक है, एट्रोफिक गैस्ट्राइटिस, क्रॉनिक गैस्ट्रिक अल्सर, कॉलिस, एक्रोआइडिया, polyposis syndrome, previous gastric syndrome, these are the risk factors for gastric cancer. The patient may be asymptomatic in the stage of gastric carcinoma, completely asymptomatic. You may not know that he has, except for this peptic syndrome. Most patients are diagnosed at advanced stage. Of course, if the pylorus has got obstructed, and that is the only time when the patient comes, then the most likely thing is he has been harboring this disease for a very long time, and therefore the disease must have advanced, and hence the prognosis is poor. वैसे भी gastric carcinoma is a very aggressive disease. ठीक है, upper GI endoscopy and biopsy, जैसे I have advised you, you can do you must do pre-operative staging. Why pre-operative staging is important? Because you want to know how far the disease has spread. So remember, मैं पहले भी आप लोगों को बताया होगा, staging is imaging. You have to do some kind of imaging. In this case, CT scan is a very good imaging modality. You will see the thick-walled stomach, may show liver metastasis, free fluid, as you can see here, which is the sighting. These are all signs, or you can see omentum nodularity, which means that there is a omental deposit. Now, all these signs are suggesting advanced disease. So, if you don't have an advanced disease on CT scan and you have a disease which on endoluminal ultrasound, if that modality is available within the wall of the gastric wall, then you will consider surgery as a treatment. PET scan is done in order to see for distant metastasis like lung, brain, bone. So, it is recommended to be done. Before you perform a surgery, before you give him a laparotomy, try to give him a midline wound, try to do a diagnostic staging laparoscopy. because some of the deposits in gastric carcinoma can be notoriously small and may evade imaging. Therefore, you physically see by putting in a small incision around the umbilicus, putting in a scope under general anesthesia before doing a surgery, and you examine the belly. If you find that, God forbid, there is some peritoneal deposit, take a biopsy and send it for section. It will tell you whether it is positive malignant है या नहीं. अगर malignant है तो ये अब क्योर नहीं आप करेंगे क्योंकि आपको रिसेक्शन करने का कोई फायदा नहीं होगा. You won't be able to cure by surgery. अगर spread नहीं है तो of course what you will do? You will do यार तुम लोग ने मेरे पूरे लेक्चर की नस्तियां नाश कर दी है यार. तो मैं जंप कर रहा हूँ. You will perform surgery and you will do resection. You will resect, either you will do distal gastrectomy or total gastrectomy depending on where the lesion is. But in gastric outlet obstruction, it is usually distal gastrectomy. Distal gastrectomy. Proximal का मतलब करीब, distal का मतलब आगे. Distal means distal half, यानी जो पाइलोरिक एंड है उसको आप रिसेक्ट करते हैं. मार्जिन मस्ट बी नेगेटिव. तो इसको करने से पहले यू मस्ट हैव टू सी द duodenum. The role of chemotherapy now is coming ahead with newer drugs and even new adjuvant chemotherapy. जहाँ पे आपको disease unresectable लग रही है, you can give them new adjuvant chemotherapy. Now before I talk about, जैसे मैंने आपसे कहा टोटल गैस्ट्रेक्टमी, इसमें क्या करते हैं? यू रिमूव द एंटायर स्टमक का जो पूरा स्टमक पाइलोरस इंक्लूडेड, लाइक दैट, एंड यू डू अ रू एंड वाई रिकंस्ट्रक्शन. सब टोटल गैस्ट्रेक्टमी भी होती है एंड डिस्टल गैस्ट्रेक्टमी भी होती है, व्हिच इज करेक्ट. ट्यूमर इज देयर, यू टेक इट आउट, एवरीथिंग इज आउट, एंड यू मेक अ न्यू गैस्ट्रिक डिजीज. ओके, करेक्ट. यू सी दिस duodenal and okay. अब अगर if you don't have a resectable lesion, then what you do? You can actually, इनको स्लाइडों को भी ऊपर नीचे तुम लोगों ने कर दिया यार दोस्त. And what you can do is, आ गया यार, what is known as pyloric stenting. मैंने अभी ये स्लाइड देखी थी ना, कहाँ गई स्लाइड? Yeah. If you want to palliate this obstruction, instead of opening up and doing a gastrojet, which you can do if you don't have this stenting facility available, but we have gastric. So what we do is you put in endoscopically, you go in, put a guide wire across it, and put in a stent, as you can see. It relieves the obstruction, and then you can plan patient for chemotherapy. Now, a brief word on how the tumor spreads. The spread is either direct invasion into the adjacent organ, mostly the pancreas, colon, and the liver, में, via the lymph node, via the blood vessels to the lung, liver, and bone, and transperitoneal, which is known as transphyllomic. You can have disease in the pelvis, peritoneum deposited. Rectal examination will make you feel a pelvic shelf. It is also known as Krukenberg tumor, and you can have a Sister Joseph nodule at the umbilicus, hard nodule, and that is also a sign of metastasis. Now, ये आपको बता रहा है कि how different type you can have. Exophytic type, you can have an ulceration, a superficial flat lesion type of gastric cancer. Okay. Polypoidal, fungating, ulcerating, infiltrating. Okay. The staging is important. जो हमने कहा था imaging हम करते हैं, वो staging उसकी TNM होती है. All tumors have TNM staging. T is for the tumor itself, N is for the nodal status, M is for the metastasis. अब इसको याद रखना, हर कैंसर का मुख्तलिफ होता है, मगर one thing you must remember, MO means no metastasis, M1 means metastasis, NO means no nodal involvement, 1, 2, 3 is nodal involvement according to the number or according to the site. Now, T actually is the tumor depth involvement. And if it is TIS, it is carcinoma in situ, which is high-grade dysplasia. T1 is tumor has grown through the lining into the connective tissue. T2 tumor has grown into the inner muscle. And T3 is spread through the outer lining, but not any other tissue organ. And T4 is when it actually invades the other. So T and M staging, you must remember about, and this is what it is. ये स्लाइडें तो इनके पास होंगी ना, ये स्लाइडें तो इनके पास बाद में भी होंगी, तो बस सही। तो ये आपके पास आपके सामने है your T and M classification for the gastric cancer. Okay.